second speaker, Dr. Mai Adel Al Samahy. She is going to speak about imaging of perianal fistula, recent insights.
Good morning, my dear professors and colleagues. Today I'll be presenting a short talk about recent insights of imaging of the perianal fistula. I'll be mainly covering a newly developed or a newly discovered fistula tract, which is not covered under the conventional classic Parks classification and St. James classifications. So, at first I'm going to give a quick recap over the definition and the different classification methods. What is a fistula? A fistula is an abnormal tract that connects the anal mucosa, the inside of the anal mucosa, to the surrounding perianal skin. So, why does this happen? We have two etiological causes. The primary perianal fistula, which is much more common. It usually results from obstruction and infection of one of the anal mucosal glands, followed by an abscess formation and a tract formation. The secondary causes usually occur as a result of inflammatory bowel disease, malignancies, or maybe iatrogenic after a recent anorectal surgery. So, what is our role as radiologists? Our role is actually not to diagnose the presence of a fistula, because most fistulas are already clinically confirmed. So, our role as radiologists is to provide a roadmap for the surgeon, a roadmap for a proper intervention to allow decreasing the recurrence rates and as well, preserve the fecal continence for the patient, which is a very important matter. So at first, the normal anatomy of the anal canal, we usually refer to the anal canal as a tube within tube configuration, where here there is the internal anal sphincter and outside is the external anal sphincter. The outer tube, which is the external anal sphincter, is formed of three components. The deep part, okay, it's like a continuation for the levator ani and puborectalis muscle, caudal continuation. Caudally, after the presence, after the presence of the deep part is the superficial part, followed by the subcutaneous part, which is present at the lowermost part of the anal canal, forming a J-shaped configuration where it curves intromedially. So, a quick recap over Parks classification, which we're all used to. Parks classification is a very important classification as it's based on the surgical plan. Parks classification categorizes the fistulae dependent on their anatomical relation to the sphincteric complex. There are four types. First, the intersphincteric fistula, which is around 45% of all fistulae. It starts from the internal anal infected gland, courses within the intersphincteric plane after piercing the internal anal sphincter, and then opens into the skin of the perianal region without piercing the external anal sphincter. Second is the transsphincteric fistula. The transsphincteric fistula pierces both sphincters, the internal and external anal sphincter, then ends in the skin of the perianal, the skin of the perianal region. The suprasphincteric, this is a special type of fistula which pierces the internal anal sphincter and travels in the intersphincteric space. Thank you, doctor. Thank you so much. And travels in the intersphincteric space and then pierces the levator ani, courses caudally down in the ischiorectal fossa fat, and opens within the skin of the perianal region. And lastly is the extrasphincteric fistula, whose opening is usually high. It's present in the rectum, low rectum, just prior to the anorectal junction, and it courses a short course within the true pelvis, then pierces the puborectalis and levator ani to end in the skin of the perianal region as well. Another classification, which is a bit less popular, is the St. James classification. It depends on landmarks on the axial plane, as well as the presence of secondary tracts or abscess formation. It has 5 grades. Grade 1 is a simple linear intersphincteric fistula tract with no abscesses. Grade 2 is an intersphincteric fistula with an abscess formation, like here, okay? Or a secondary tract. It might not be an abscess, it might be a secondary branch or tract. Grade 3 is a transsphincteric fistula with no complications, with no abscess formation and no side branches. Grade 4 is a transsphincteric fistula with an abscess formation. And lastly, grade 5 is a suprasphincteric fistula. Okay? So we'll have quick examples. This is a simple linear intersphincteric fistula tract piercing the internal anal sphincter but preserving the external anal sphincter with no abscess formation. So this could be classified as grade 1 according to St. James classification. This is a simple transsphincteric fistula as it pierces both the internal and external anal sphincter as we see here. Okay, so this can be considered a grade 3 according to St. James classification. This is our last example here. It's a transsphincteric fistula with an abscess formation. It pierces both sphincters as we see here, and it's complicated with an abscess. So this is grade 4 according to St. James classification. We're done with the quick recap. Now we're focusing on the primary role of my presentation, talking about the special types which are not recognized within the parts and St. James classification. The first of such types is submucosal fistulae. Submucosal fistulae are actually superficial fistulae whose internal opening is very low in the anal canal, that it doesn't pierce the internal or the external anal sphincter and courses a short course after which it opens into the perianal skin. The second is the pyloneedal sinus. It's a superficial tract. It's actually not a fistula. We have an infection localized within the subcutaneous tissue with no communication, totally included within the subcutaneous tissue with no connection to the internal anal canal. And the last but not the least, this is actually the star of our presentation, is the rifle fistula. The rifle fistula is the short form for anal fistula at roof of ischiorectal fossa inside levator ani muscle. So as the name implies, the fistula is located, part of the fistula is located at the roof of the ischiorectal fossa. It starts within the internal anal mucosa, pierces the internal anal sphincter and pierces the muscle of the external anal sphincter, but remains confined within the fascial covering of the external anal sphincter complex, and thereby doesn't have a component within the ischiorectal fat. And that's the differentiating point between it and the transsphincteric fistulae. This is a schematic illustration of the outer sphincteric space where the rifle fistula occurs. Here is the internal anal sphincter, followed by the conjoint longitudinal ligament, and then the classical intersphincteric space or the middle intersphincteric space, followed by the external anal sphincter and the fascial covering. The very thin line between the fascial covering and the actual muscle is called the outer sphincteric space, and this is the place where the infection is centered in our rifle fistula. This is an MRI illustration of what we just said. The blue asterisk is representing the internal anal sphincter. The yellow one represents the intersphincteric space, while the red one represents a potential space between the serosal covering and the muscle of the external anal sphincter. We will have some examples to make this more clear. As you see here, this is an example of a 19-year-old boy who has a suprasphincteric fistula, okay? He has a suprasphincteric fistula starting in the true pelvis and piercing the levator ani muscle to continue within the ischiorectal fat. But there is also a rifle component seen here, a component seen within the intralevator muscle. Okay, how can we differentiate? How can we know that this component is actually within the muscle, confined by the fascia? We don't see any fat plane between the muscle fibers and this component, and the rifle component. This is another example of a 40-year-old male patient presenting with such a complex fistula. He has a transsphincteric fistula tract with a horseshoe component traversing to the opposite side and bilateral rifle components. These are the bilateral rifle components marked by the circle. As you see here, there is totally no line of separation, no fat between the muscle fibers and the collection here. So what's the importance of this rifle component? As I said before, our role as radiologists is to provide an accurate roadmap to ensure a proper surgical intervention. The rifle component is sometimes tricky during drainage. It's not accurately drained with the typical fistulotomy. Let's look at these two schematic illustrations. This is for a patient having a horseshoe-shaped fistula with bilateral rifle components. Though it sounds very complex, but this patient can be easily drained through the skin opening here, which will reach the rifle component, and another skin opening here, which will also reach the rifle component. Okay? But this patient is much more tricky. He has an apparently simpler fistula. But as you see here, this is the outer opening. If the surgeon doesn't have any idea using the MRI about this rifle component, he will just use this as a pathway for drainage. And this part, this rifle component will not be drained. So in such cases where the rifle component is not easily drained through the outer opening, we have to take like a dedicated pathway through the internal anal mucosal opening here. So one of the very important differentials between rifle and is high transsphincteric fistula. It's very important to differentiate between both. As we said, they have different surgical approaches. The high transsphincteric fistula will be mostly drained through the skin. But the rifle fistula, as we said, might need another pathway, an additional pathway. As we see here, this is a high transsphincteric fistula, and this is a rifle fistula. There is an amount of fat, a considerable amount of fat, separating this fistulous tract from the thinned out levator ani here. But here, we cannot differentiate the collection or the tract from the levator ani. So to sum up, to have a take-home message, which I believe could be beneficial if we follow, I will just give a brief about the points that we should cover in a radiology report. At first, we should state the presence of a tract. We should describe it as active or inactive or chronic. An active tract usually has high signal intensity in both T2 and STER, unlike a chronic tract where fibrotic hypointense T2 fibers and hypointense STER fibers are present, as we see here marked by the green arrows. We should as well describe the internal anal opening as regards its o'clock position. If the patient is in lithotomy position, 12 o'clock will stand for the anterior perineum, and 6 o'clock will stand for the natal cleft, 3 o'clock will be on the dead left, and 9 o'clock will be on the dead right. And this is how we localize the position of the internal anal opening. Also, we should state the length at which the anal opening is present from the lower end, from the anal verge. We measure this in a coronal image, as we see here. We should be aware of any complications, an abscess tract, a secondary branch, any possible complication should be mentioned in our report. Also, we should give a proper idea about the secondary branches. Some fistulae are so complex and branching that you cannot actually know where is the main tract. In this cases, we usually describe these fistulae as complex fistulae, not complicated. Complicated fistulae are fistulae with abscesses, but a complex fistula is one where you cannot know the main branch and the secondary branches. So we just describe this as a complex fistula, and we try to describe almost all the branches regarding their course to help the surgeon adequately drain those fistulae. For sure, we cannot forget to give a proper a proper anatomical description of the fistulous tract in relation to the sphincters, and thereby describe it according to the Parkes classification. And last but not least, please don't forget to mention the presence or absence of rifle component. And if we if a rifle component is present, it would be great if you guide the surgeon by mentioning whether or not it has a connection with the skin opening. Thank you. Thank you so much.
شكرا.
عفوا دكتور.
سؤال بس بسيط. Why you include the bilingual sinus in this subject?
I understand it's not a fistulous tract. It's not an actual fistulous tract, but you know, doctor, when it comes as a study, as a perianal study, it's a sinus, but it's one of the pathologies that we do the study for. So I'm just including this like as a clarification for a more junior radiologist.
It's a
that
separate
this is not
entity.
An actual fistula. Yeah.
And sometimes perianal fistula presented as a bilingual sinus.
Yeah. Yeah.
With
Right.
the tract extending to the natal cleft.
Exactly.
But it's a separate entity.
It's a separate
right?
entity.
Thank
Sure.
you.
Thank you.